Hard. Um, okay, I'm going to do that over again. Welcome, everyone. My name is Kathy Waligora. I am, you see your pronouns. I'm the Deputy Director of External Affairs at EverThrive, Illinois, and we welcome you to this webinar. We're going to talk about what's at stake for healthcare in Illinois in light of the incoming Trump administration and Republican Congress. Before we get started, just a bit of housekeeping. So folks are coming in, cameras off, muted. We would, encourage you to stay on mute. We'll ask you to stay on mute for the duration of the presentation. There's a lot of you and a lot for us to cover, so we want to minimize distractions. We will, as you saw, be recording today's presentation, and we'll share the recording and slides with everybody tomorrow, as long as the tech gods cooperate. We'll be asking folks to use the Q&A box. I was trying to click to show you where it is. I'm sorry. So we'll use the Q&A box that you can access on the bottom of your screen to answer questions throughout the presentation. We're going to answer questions, if possible, in writing as we're speaking. We'll try and answer some questions at the end if we have time. Using the Q&A box will allow us to make sure we see your question. If you want to show love to our speakers or otherwise make a comment, that's what the chat's for. You can see here our agenda for today. We're going to do a very quick refresher on the Affordable Care Act and Medicaid in case that's helpful to folks. Spend most of our time talking about what we see as the biggest threats to healthcare in 2025, reviewing some of the specific Illinois impacts and solutions, and we'll close by talking about how we're going to move forward and do this together. Before we move on to the next slide, want to thank my colleagues and co-presenters who helped to plan and are going to be speaking with you today. So thanks to Stephanie Altman at the Shriver Center, Timothy Jackson and Nadine Israel at AIDS Foundation, and Carrie Chapman from Legal Counsel for Health Justice. I appreciate you guys. And Jordan Hester, who's helping with tech. We will jump into the presentation. Before we do that, I want to talk to you a little bit about Protect Our Care Illinois. So we're here with you today on behalf of Protect Our Care Illinois. For those of you who are unfamiliar with this coalition, we were founded in December of 2016 to respond to threats from the first Trump administration and that Republican-controlled Congress. We grew the coalition to include more than 65 organizational members from across the state, and we led what I thought was a really incredible effort to mobilize thousands of people in defense of healthcare. We turned out folks to town halls and meetings and press events and rallies. It was really exciting, even though we would rather have not had to do it. We're now relaunching with that same spirit to defend against the threats to healthcare from this Trump administration and this Republican-controlled Congress. I'll talk more about how you can get involved with Protect Our Care at the end of today's presentation. So I'm going to give you just a very brief overview, refresher on the Affordable Care Act and Medicaid. You're going to see a lot of content on the slides today. I won't be covering everything, nor will the other speakers. We wanted these to be available to you as a resource following today's presentation. So just know that you're not missing something if you feel like you can't keep up. So starting with Medicaid. Medicaid, put simply, is the nation's health insurance program for people with low income. Folks who qualify for Medicaid generally fit into a couple of categories. There are what we think of as the traditional or sort of historic populations. Those would be kids, parents and pregnant people, people with disabilities, and older adults. We also, in 2014, under the Affordable Care Act, expanded Medicaid to cover low-income adults without dependents through what we call the ACA adult population or the expansion population. The most important thing to understand about Medicaid is that it is a federal-state joint partnership. What does that look like? For every dollar the state spends for traditional Medicaid, those populations I listed first, we receive a reimbursement of 50 to 63 cents. And for every dollar we spend on the expansion population, we receive a reimbursement of 90 cents. So the federal government is covering 50 to 90% of all costs of the Medicaid program. That's true in every state. Importantly, the Medicaid program operates as what's called an entitlement. If people are eligible and qualify, like apply for Medicaid, the Medicaid program is going to provide the same benefit to them. that benefit expands, that sort of pot of money to cover that expands and shrinks with demand. That allows us to respond to things like pandemics or recessions, which might result in more people needing that extra support. That growing match, that 50 to 90% match, is often referred to as the FMAP or the federal match, and you'll hear those two phrases a lot today. Understanding this relationship, the funding partnership and the entitlement, is crucial for understanding what's at stake in the coming year. To give you a sense of the scale of this, in fiscal year 2023, Illinois received $21 billion in federal funds for Medicaid. That's about 65% of our total spending. The state only spent about $11 billion in that same year. To put briefly, obviously, we've talked about the way that Medicaid provides health insurance and access to healthcare, but it's really impossible to overstate the importance of Medicaid in the overall healthcare system. Medicaid is the largest funder of long-term care services, substance use and mental health services. Medicaid covers about half of all children nationally and about half of all births nationally. And Medicaid plays an outsized role in certain communities. Rural hospitals, rural healthcare providers experience a lot more are much more, find Medicaid to be a much more important part of their overall payer mix. And of course, Medicaid plays a key role in pandemics, for example, as the largest funder of HIV and AIDS services nationally. Turning to the Affordable Care Act, this one we couldn't have done days-long trainings, but to put it very briefly, the Affordable Care Act is essentially our national health insurance law. It has a couple of hallmarks. It created pathways to coverage, including and especially through the creation of health insurance marketplace or health insurance exchanges. It perhaps most famously provides protections for people with pre-existing conditions. For example, banning denials based on your health status, eliminating or not allowing insurance companies to charge people more because they were sick, and requiring all plans to cover certain essential health benefits. And it also imposes regulations and consumer protections on the entire health insurance industry that really protect all consumers, or nearly all consumers, with health insurance in our country. It also provides financial assistance. So for folks who buy health insurance in the marketplace, about 80 to 90% nationally find that they receive some sort of financial support to decrease their monthly payment on health insurance. In Illinois, that support, in every state, it comes in the form of what's called the advanced premium tax credit. But in Illinois, that support averages about $560 a month. There's a huge amount of money that's coming in to support people in Illinois. And finally, the last slide in our overview is who does this help, right? In Illinois, about 3.4 million people are enrolled in Medicaid. That's a third of our population. We also have 400,000 people who are purchasing health insurance through the marketplace. And again, more than 80% of those folks are receiving some sort of financial support, averaging over $500 a month. So these two programs are a crucial part of how people access health insurance and health care in our state. Again, about 1 in 3 kids in Illinois, 50% of births are covered by Medicaid. And nearly every single person with health insurance in the country benefits from the ACA consumer protections and regulations. And that's because we do a lot of really good things in Illinois around health insurance, but we can't regulate other states. We can't regulate certain plan types, and the ACA can cast a much wider net in terms of ensuring health insurance works for us. So I know that was a really brief or really fast overview, but we wanted to make sure we all had that same level going into the conversation about federal threats. So I will turn it over to Carrie.
Hey everybody, Carrie Chapman, she, her pronouns, from the Legal Counsel for Health Justice. And unfortunately, I have the sad news of talking us through the federal threats. We can go to the next slide. Okay. So I think if you take sort of nothing else away from this discussion, you should understand that whatever is being talked about at the federal level right now is a cut to Medicaid. So it may be called any number of things. It may be really detailed and wonky. It may be very big picture, but everything comes down to a cut. Everything being proposed is a cut. And the reason that the right now, the discussion in Washington is about cutting Medicaid, is that there is a early agenda of this administration and the incoming Congress to extend and make permanent tax cuts, primarily tax cuts for high-income folks and corporations, um, and to increase immigration enforcement. And in order to do that in the way they want to do it very quickly, and with only 51 votes in the Senate, they need a pay for. They need a pool of money that they can draw on to finance those tax cuts and that increased immigration enforcement. And the bucket that they're talking about looking at explicitly is Medicaid. And this aligns with something that we've known, if you've been in this space for a long time, that there's been an agenda to cut Medicaid for a very long time, really since the 80s and 90s. And so this aligns ideologically with an agenda to cut the Medicaid program. So if you hear the words changes to federal match, work requirements, per capita caps, eligibility restrictions for nursing home coverage, a change to EPSDT, all of these wonky terms come down to one thing, which is a cut to Medicaid. Next slide. So here are some of the things that have been discussed and put on the table by the current administration and its supporters related to both the ACA and Medicaid. So one is to let the enhanced premium tax credits for the marketplace expire after 2025. They exist through 2025, and we know that the enhancement of those premium tax credits created a big bump in enrollment in marketplace insurance. And so we will, if those enhanced tax credits are cut, we will see people finding marketplace insurance unaffordable and disenrolling. Also cutting Medicaid, so reducing FMAP or federal match to 50%. So in Illinois, we generally get about 50 cents on the dollar reimbursement. Other states are as high as 80. Again, as Kathy said, Medicaid is an enrollment. And so there's talk about an entitlement. There's a talk about ending the entitlement, which means that states could put wait lists on their Medicaid program and other limitations on their Medicaid program. So instead of, if you are financially eligible and a resident of Illinois, you apply for Medicaid and you get it, you might not. Also work requirements. And then an important fiscal lever is to limit states' abilities to use provider taxes, healthcare provider taxes, to finance a portion of their Medicaid program, which is super important to Medicaid financing in Illinois and in most other states. There are also some less obvious cuts, like expanding the privacy risks for immigrants in state and federal health programs. So suggesting that ICE is going to try to get information about people who are receiving benefits or applying for benefits for a U.S. citizen household member, which we know will cause people to disenroll their U.S. citizen children from Medicaid out of an understandable fear of being targets. That's essentially a cut to Medicaid. And then there have been a lot of really good recent federal regulations that have made the Medicaid program stronger and easier for people to use and keep. So basically get and keep. Those rules are subject to being rescinded, which will then make it harder for people to get and keep Medicaid. And that is essentially a cut as well. Next slide. So I know this seems somewhat overwhelming, but it is really important for us to understand that these cuts are going to come from various different places. And part of the role POCIL played in 2017 and forward, and hopes to play now forward, is to keep our ear to the ground when any of these different vehicles for cuts are starting to be deployed, and letting you know what your response might be able to be to those. So obviously we could have just Congress acting, passes a statute, president signs. We could see federal rulemaking, so regulations being promulgated by federal CMS that are problematic. Much of the Medicaid program runs on what we call, in the wonky world, sub-regulatory guidance. So nothing as official as formal regulations, but all sorts of guidance and state Medicaid director letters and policies. Those can be changed. Expanding enforcement of punitive parts of the law already on the books. And so looking at every aspect of Medicaid that kind of trips people up or makes it difficult to get on or stay on, and really leaning into those. And then, as we're all concerned in Illinois, scrutinizing states with robust Medicaid coverage and targeting states like Illinois for increasing oversight or administrative burdens, merely to punish us for having a generous program and trying to get us to pull it back. Next slide. So we understand that for every 10% reduction in that federal match, so let's say for ACA adults, the Fed said we're going to go from 90% match to 80% match. For every 10% reduction in FMAP, that's about an $80 million loss to the state. So, for example, if Congress said we're going to align Illinois' FMAP, federal match, for ACA adults with their regular Medicaid population, so we went down from 90 to 50% match, we would lose $3 billion with a B dollars. And it is clear that we would be facing coverage losses, eligibility losses, with losses of money of that magnitude. And more concerning in Illinois, we have what you might hear called a trigger law. So in our initial statute expanding Medicaid, taking the Medicaid expansion from the federal government when it was first offered, we put language that said that if the FMAP goes below 90%, that 90 days following, we end our Medicaid expansion program by operation of statute, meaning no one has to take an additional act. At the end of the 90-day period after the FMAP goes down, our expansion program ends. And in Illinois, if it ends, 750,000 people will lose coverage. And again, nothing needs to happen for the program to end. That is what is in statute now. So FMAP goes down, 90 days pass, nothing else needs to happen, and MedEx doesn't exist in Illinois. Next slide. So super concerning, obviously, because there is a lot of discussion about reducing federal match, because that is a very quick and easy way for the federal government to get a pot of money that they can put to tax cuts and extreme immigration enforcement. And obviously, with Kathy's introduction to the role of federal match in Illinois' budget, we are not in a position to make up billions of dollars of lost federal revenue. We would have to make changes to Medicaid in order to respond to the magnitude of cuts that are being seriously discussed. This is not money in the couch cushions, right? This is money that would require, money loss that would require us to change the program. So work requirements for Medicaid, as sort of backwards as they might seem, right? It seems like to me, you need to be healthy in order to work, but work requirements suggest that you have to work in order to have the privilege of having access to healthcare. Are a hot topic in Washington right now. Only one state actually imposes work requirements, and the evidence in that state and the evidence in Arkansas, which no longer has them but had work requirements until a lawsuit, was that, again, people just lose coverage. So again, work requirements are a cut. Because it is incredibly difficult for individuals, and then it is incredibly burdensome for state employees to try to process proof that you are working to the level that you need to be to have Medicaid regularly, right? This isn't something that you prove once. It's something that you have to routinely prove. So you have to have proof, huge burden on Medicaid recipients. And then also the state has to timely process that. And so essentially what happened in Arkansas and also what's happening in Georgia is that work requirements just mean people lose Medicaid, and that is a cut. It's possible that right now, work requirements that would be imposed just by federal CMS, by regulation or by policy, would have to be a choice for states, and Illinois would not choose to take up work requirements. For there to be work requirements mandated on the state of Illinois, that would require a change in the Federal Medicaid Act. It's important for us to think about work requirements, but so long as they would just be an offer for states and not a requirement, Illinois is probably unlikely to take them up. And there's lots of, because they've tried this, you can go to those slides or go to those sites and find details on what the coverage losses look like. We have a massive 1115 waiver, which some of you all may have heard of. So 1115 waivers are basically opportunities for states to pilot new and interesting things that would actually not be permissible under the traditional Medicaid Act. So you get that portions of that law waived to do something creative and new in the hope that you will have better healthcare delivery, better outcomes, lower cost. And we have a huge 1115 waiver that is intended to address social determinants of health that was approved. And we are investing a lot in our efforts under this 1115 waiver because those 1115 waivers are sort of ongoing, part of an ongoing relationship between Illinois and CMS. We are concerned about what restrictions or reporting, et cetera, that CMS might put on this waiver. Illinois has basically taken advantage of many of the flexibilities that the government has provided, CMS has provided historically to the Medicaid program. If they pull back on those flexibilities, then our program will run less smoothly. So we have done a lot to simplify Medicaid enrollment and retention here. We could lose the ability to do that. We could be forced into restriction of coverage by tightening verification of eligibility. So we have a fair amount of self-attestation and other pieces to verify your eligibility, which, you know, the process for becoming eligible for Medicaid is very onerous and requires a lot of documentation. And we've done a lot of streamlining of that with self-attestation, et cetera. And all of those flexibilities that have helped us keep people on Medicaid through the massive redetermination project that we just went through, in which Illinois was a leader in the nation for keeping people on Medicaid, but the tools that we use to keep people on, the feds could pull back. And we could try to challenge some of those rules, and I think there's appetite to challenge rule changes in Illinois. But obviously we're concerned about Supreme Court cases, about administrative law, and those would be administrative law cases that might help the administration win, even if we make legal challenges. Okay, and I am turning it over to Timothy.
Thank you so much, Carrie, and I hope everyone can hear me. I apologize. I'm having a little technical difficulty today, but I am going to talk about really the impact of several communities. Obviously, any changes that we make to the Affordable Care Act, Medicaid, is going to impact anyone that receives those services, but we are going to speak specifically today about a couple of populations, including the LGBTQ population. And I want to start just mentioning Section 1557, which is really kind of the cornerstone of the equal protection or the non-discrimination clauses of the Affordable Care Act, which prohibits discrimination on the basis of race, color, national origin, age, disability, or sex. And of course, sex includes pregnancy, sexual orientation, gender identity, and sexual characteristics, and covered health programs or activities. And so what does that mean? That means that covers just about the entire litany of just about everyone. And so if any changes are made to the Affordable Care Act, and specifically when we talk about Section 1557, you know, those are going to have tremendous impacts for LGBTQ folks, but folks who are pregnant, all of the people that fit under these non-discrimination protections. And so those services that we're talking about, really, when we're looking at preventative care, reproductive care, gender affirming care, telehealth. I mean, just literally, again, it's the entire swath of the healthcare delivery system as we know it under Medicaid and the Affordable Care Act. And so, a Trump administration, and especially having someone like a Robert F. Kennedy Jr. being the Secretary of Health and Human Services, causes or could potentially cause great harm to these communities that we serve. Next slide. And so we can't talk about Section 1557 in the Affordable Care Act while also not mentioning Braidwood versus Becerra. If you're not familiar with this is a case that the plaintiffs basically are pushing back on the United States Preventative Services Task Force that basically object to purchasing health insurance that includes preventative service, including abortifacient contraceptives, PrEP, which is used to prevent HIV transmission, the HPV vaccine, as well as other screenings, behavioral counseling for STIs, as well as injection drug use. So again, all of the things that we are accustomed to using to provide a full comprehensive suite of care for the communities we serve, this lawsuit could potentially have a tremendous impact on whether or not we can continue having those services under the Affordable Care Act. Obviously, the United States Preventative Service Task Force, USPSTF, issues recommendations, and that grade A, grade B recommendations are all to be covered without cost sharing under the Affordable Care Act. And so basically what we're looking at a June 2024 decision by the Fifth Circuit Court of Appeals declaring that the role of the USPSTF determining mandatory preventative coverage under the ACA is unconstitutional. While that did not issue a nationwide injunction, we are awaiting right now a decision to come from the United States Supreme Court of whether they're going to take this case up. And what does that mean? That means that the United States Supreme Court could ultimately decide on whether the USPSTF is constitutional or not, but also the Advisory Committee on Immunization Practices. And of course, again, we mentioned Robert F. Kennedy Jr., immunization, vaccinations. We can kind of connect those dots. Next slide, please. And I do want to just kind of finish on, again, another community that is going to be heavily impacted. Carrie mentioned earlier the increased immigration enforcement. So when we talk about immigrants, Congress could try to restrict federal funding for undocumented immigrants through changes to emergency Medicaid. The new administration could disallow federal funding for emergency Medicaid and could also get around some privacy protections in Medicaid and the marketplace that safeguard immigrant identity. Obviously, we saw in the first Trump administration those changes to public charge and all of that, and all of the chaos that ensued from that. And so all of that is going to impact this community. So when we're talking about, all of the things that could change and all of the communities that could be impacted, we're talking about LGBTQ folks, pregnant folks, where we're talking about, race groups that are already disproportionately impacted by a number of different health disparities. All of these groups are at stake. And there are many of the communities that we serve here in Illinois. So I think we're going to go over to Stephanie Altman.
Thanks, Tim. Hi, everyone. So now we're going to get into what can we do about all of this. And this is going to take some real vigilance on all of our parts. And we're going to talk at the end of this section about what Protect Our Care Illinois did with all of our national and state advocates in 2017 and how we can gear up and organize to fight some of these changes and to defend our state and the people we have covered. So one thing we can look at is that trigger in our Medicaid expansion law. So we are one of 9 states, as mentioned before, that has this trigger that would automatically cause the end of our ACA adult program within 90 days if the federal match was lowered below 90%. We could pass legislation to amend that law and remove the trigger. We could modify it. We could extend the time out to give Illinois more time if that were to happen to figure out how to fund and continue coverage. And we could look at other kinds of ways that the state could administratively ameliorate the impact of it. But the fact is, it's in our law. So we are going to have a conversation about it. We are talking to legislators about it. We are talking to the governor's office, Medicaid agency. The state is very aware of it. Some legislators, some policymakers, weren't around when it was passed. So it is new to them. So we're continuing to have conversations, but it is something we as a state are going to have to deal with so that our program doesn't end if the federal match is lowered. We can pass legislation to strengthen some access to some of the services that Tim was just talking about, especially access to abortion medications. We can pass legislation or look at legislation to ensure privacy for pregnant people and for people receiving abortion care in Illinois to further safeguard their rights, depending on what happens at the federal level. Our attorney general is very important and was very important in the first Trump administration. The Democratic attorney generals have an association, and they have worked in cooperation with each other to bring litigation to block Trump administration actions in the first Trump administration. And we know that they are gearing up to do so this time. Us as Protect Our Care and as individuals here and organizations have cooperated and worked with the Attorney General before when cases were brought against the Trump administration in 2017 and 2018 in order to find individual plaintiffs and in order to bring those stories of individuals into the case and who the actions will actually impact. So we will be working with them as well. As you might be aware, not a moment too soon, we are launching a full state marketplace in 2026 in Illinois. So Illinois passed legislation to create a state marketplace 2 years ago. So we will move from healthcare.gov to Get Covered Illinois. We will control the marketplace. We right now, even for this year, have a state marketplace on the federal platform. But by plan year 2026, which starts January 1st, 2026, we will be launching a full state marketplace. That gives us a lot more control as a state than we had under the federal marketplace. And it is, like I said, not a moment too soon because the federal government and the changes there will now control healthcare.gov and any states without a state marketplace. The kinds of things that we can do are, whoops, go back one slide. Yeah, sorry. The kinds of things that we'll be able to do with a full state marketplace are setting our own enrollment periods, having stronger privacy protections, having special enrollment periods. We've already passed the law to have the Illinois marketplace include a special enrollment period for people who become pregnant. That doesn't exist in the federal law. And also control the funding for enrollment assistance. We can also look at other state legislation to codify Affordable Care Act provisions for state regulated plans. So the state only regulates plans that are allowed under the federal ERISA laws. But we do have a lot of very strong protections and even more that we've passed in the last couple of years. But we need to kind of look at a side-by-side of the Affordable Care Act protections and what Illinois has in our insurance code. And we may want to align those two so that no matter what happens at the federal level, we have some of these protections codified or cemented into our Illinois law. One of those things would be to protect insurers from setting any annual or lifetime limits on cost of care. We already have some mandated dependent coverage in Illinois that was pre-Affordable Care Act up to age 26, but we have a lot of qualifiers in that. You have to have had continuous coverage, you have to be unmarried, and other qualifiers. We may want to look at making that a full mandated dependent coverage, the same as the ACA. Prohibit insurers from denying coverage for pre-existing conditions. There's a few other states who've already done that. And we did pass last year a guarantee of coverage of preventative services. Next slide. So what if the state subsidies, these enhanced subsidies that Kathy and Carrie told us about are not extended in 2025? That obviously is another huge loss of federal money that helps to insure people. So we're going to fight against it. There are some things we would be able to do in terms of raising state level revenue to give state enhanced subsidies. That is done by some states. Various states use some of these ways to fund that. Fees on health insurers, issuers, provider fees. California has, for instance, the individual mandate that was removed at the federal level, but they have their own individual mandate to help pay for that, tobacco taxes and other sources. The goal would be to make marketplace coverage as affordable or as accessible as possible by reducing those premiums, especially if people start dropping out of the marketplace due to the loss of the enhanced subsidies. We could also consider additional policies. Almost every other blue state has their own state marketplace and has done this for the last 10 years. So we have a lot of states that we can look to be able to find strategies to make it more affordable. Of course, as Carrie warned us all of these become significantly less likely if Illinois is also facing huge losses in federal dollars for Medicaid. You know, we can't necessarily do all of it. I'm now going to turn it back to Kathy to talk about our coalition building.
Thanks, Steph, and sorry for getting ahead of you on those slides. All right, before I talk about coalition building, I just a little bit of housekeeping. Reminder, we've seen some already, but if you have any questions, put them in the Q&A. We may respond in writing, or we can answer questions at the end if needed. And just a reminder, everybody will receive the recording and the slides via email tomorrow, so you'll be able to review everything, click all of these links, and really see what we've provided for you. So thank you to Stephanie, Carrie, and Timothy for covering the wide variety of ways that things can go really bad and some of the things that we can do at the state level. As we can all see, there is a clear and present danger to healthcare access in the coming year, but it is not insurmountable. It is not a foregone conclusion. I am remembering a lot lately how I felt in December of 2016 as we were bringing this coalition together then, and a lot of the media, a lot of the discussion, a lot of the conversation, a lot of our assumptions were that things like the Affordable Care Act would be completely repealed without replacement and we would be rebuilding. There was a lot of fear around Medicaid block granting. Those fears are real. We need to be responding to those very real threats. But as you all know, things went overall pretty good. I'm not saying there were no harms, but we protected the framework of the Affordable Care Act. We slowed down a lot of efforts that would have otherwise been incredibly damaging, allowing us to stop them. We did not see a block grant or per capita cap to Medicaid or even widespread work requirements. So I'm reminding myself a lot that we know how to respond in this moment, that the threats are real and need to be taken seriously, but we've got a lot of history and a lot of skills that we can build on. Organizing, working together, and mobilizing at the state level really does matter, and it really is important for responding to these types of proposals. So I want to talk a little bit about how we're going to do that. So the moral of the story is we can learn a lot from what worked in 2017 in the ACA repeal fight and Medicaid fights. But what we did in 2017 is what we've done in a lot of other issues a lot of times in the past, right? It's pretty straightforward, organizing and advocacy. What matters is that we are ready to go early, that we are strategic in how we do this, that we are coordinated in how we do this, and that we don't let up. We can all take breaks to rest, but we need to be working together to make sure that the pressure stays on the members of the Illinois congressional delegation, especially our 3 Republican members, to defend healthcare access. Some of the things that we did in the past that worked really well, right? We mobilized folks. So I think I mentioned at the beginning, we worked with organizing partners across the state, like Citizen Action and Divisible, to organize consumers by educating them about what was coming and turning them out at events, connecting them to the media, hosting rallies that really demonstrated the groundswell of opposition to these proposals from the top of the state to the bottom. We did that in part through a lot of sort of analysis and material development and information development. You're going to see that again from us. We are already working on some fact sheets that kind of go over the most important things to know about what Medicaid and the Affordable Care Act mean for the state. We are looking at some sort of state, they call them Trump proofing, right? That's what they're calling it in the news. Some state measures that we might consider taking to proactively defend healthcare. And we will be doing a ton of analysis of proposals as they come out. We will work with our friends in Congress. We will work with our friends in the state to make sure that we're all sort of on the same page about that and moving forward as in as coordinated a way as possible. We also will understand, when do we go to Congress? When do we go to the administration? When do we go to the courts? Using the entirety of the government system, the checks and balances to the extent that they exist, to defend access to healthcare. And finally, and perhaps one of the most important things we'll do, is use stories. Stories are so important, and we saw this in 2017 in a really big way, for humanizing the programs, policies, laws that exist, for really demonstrating how important programs like Medicaid are today, right now, in folks' physical, emotional, mental, and economic well-being. But also to say, if this program is working really well for me today overall, and you cut it in this way, what would that look like for me? We connect storytellers, again, bringing them out to the media. Those media placements are super important for bringing light to things that folks want to do in the dark, members of Congress want to do in the dark. We also bring folks out to rallies. They help motivate all of us when we hear how real and how serious this is. And when we share them with our friends in Congress, with our members of the congressional delegation, like Senator Durbin, Senator Duckworth, Representative Underwood, and others, so that they can share them in their media work, and they can read them from the floor, and they can share it with their colleagues, because it really does change how people look at these programs to hear stories. It can sometimes feel almost too simple, can feel almost too easy to just lift up stories, but it's so, so important. This is an example of the type of story that we would share. David shares his experience of a pretty serious healthcare crisis, how Medicaid helped him get the things that he needed to be well after that, and what it means for him that he is able to continue to live life on his terms, as he says, to be able to pursue the things that make him happy, to pursue the work that gives him fulfillment or pays his bills, right? Whatever that looks like, spend time with people he cares about. These types of stories are going to be really important. I want to make a plug now. If you are somebody who's in a position to help us collect stories like this, especially in rural communities, downstate, where it can sometimes be a bit more difficult for those of us up in Chicago to do that, we would really, really appreciate your support. What are we going to do? I explained to you what we did in 2017. At the moment, the playbook looks really similar. What we know is that we will begin to see proposals to cut Medicaid and potentially other health and social services in January, whether that's January 4th or January 26th, maybe it'll be February 1st. We know it's coming. It's coming fast. This Congress wants a win in the first 100 days, and they're going to try and move their tax cuts, which will require spending cuts, quickly, and they're going to try and hide the impact on these programs that support everyday people. It will be our job to use all of the tools in our toolbox to shine light on what they're doing. We're not going to let them do it secretly. We're not going to let them hide what they're trying to do. And in doing so, to slow it down. Every day that we buy in preventing these kinds of cuts from happening, preventing these sorts of proposals from advancing, gives time for all of our partners at national organizations and in other states to do the same. So that will be our focus. We will do that through using the media. We will do that through analysis of federal proposals and putting forward both proactive and responsive state protection. We'll look at working with our congressional delegation, state legislative leaders, to educate them and help them consider actions. We will do story collection. We will generate data. We will share the great data that's coming out of some of our national organizations, out of our state agencies. And we'll look at telling the full story of Medicaid and the ACA. You've heard us do that today. It's not just connecting people to healthcare, though that would be enough. There is this great sort of system of tendrils that Medicaid puts out that we want to make sure folks can see. What can you do? So we've told you a lot about what we're worried about. We've told you some about what we're pulling together in the last, month, little over a month since the election. I want to talk about what you can do, because the only way we're going to get through the next 4 years in so many ways is to wrap our arms around one another and take care of ourselves and our communities. And a big part of that has to be showing up and fighting bad proposals when they happen. We know that Medicaid is a popular issue when people start to talk about it. Folks do not want to see anybody losing access to healthcare. The Affordable Care Act is popular when people talk about it. And so we are going to be talking about it. Like I said, we're looking at January. So I think a lot of folks hopefully are going to have a break over the holidays, take some time, rest up, and let's move into defense as soon as we get back. We are sort of finalizing the infrastructure of Protect Our Care Illinois. So you will hear from me in January when we have an opportunity to share with more about how you can officially join and support Protect Our Care. In the meantime, you can sign up for AIDS Foundation's Text Mobile Action Network by texting AFC to 4069. And you can sign up for EverThrive's Action Network to receive updates on what we're doing as well. I'm not going to spam you all who registered with a ton of emails, but I will send one follow-up email with information on how to join. The last thing I want to say, I saw it in the chat, and I just want to acknowledge and thank our friends from Senator Duckworth's office for being a part of this conversation and joining us and sharing your information. We are really looking forward to working with everybody on this call, including our friends in Congress. I don't want to be here, right? I don't want to be defending healthcare. I want to be thinking about how we expand and how we're proactive and making things better for all of us. But if we're doing this, we really do have a great team here in Illinois of advocates, of researchers, of legislators. And I think we'll once again do some really cool work. And truthfully, the more we can tell the story of the ACA and Medicaid, the better prepared we are to advance and expand access to healthcare once we are past this threat. We shared a bunch of resources throughout the slides. Here's just a couple of our favorites. Like I said, you'll all receive these slides tomorrow, making it easier to click the links. But I do want to make a plug for Protecting Immigrant Families. Timothy talked a bit about this. Our immigrant neighbors are going to face a lot of really serious harm on a lot of fronts. We cannot achieve health equity in a system of mass deportations, in a system, in a context of the rhetoric we're already hearing about our immigrant neighbors. So Protecting Immigrant Families Illinois is another coalition started in the last Trump administration, continuing to do great work, reconvening right now. So I wanted to make a plug for that specifically. And questions. While I've been talking, it's been hard to look at the chat, but I've seen there's a lot of action in the chat. I don't think I see any questions in the question box. I don't know if anybody has any questions that they want to share. Oh, I guess there's one question. Are we working with the Illinois Single Payer Coalition at all? I know we have worked with them in the past. I don't know if they're a part of the coalition right now as we're getting back up and running. But like I said, we'll share information in January about how folks can join. And we welcome anybody who shares in our mission of defending access to healthcare to be a part of this.
Hey, Kathy. So I think we answered most of the other questions, so it probably shows that the Q&As were answered. There were a couple specific ones, and I know, Anne, you had a couple specific, so I direct messaged you so we can talk about your individual clients and the people you're working with more privately with my email. Were there any others, Carrie, Nadine, that looks like we answered?
I think we answered all of them. You know, generally, I didn't get a chance to dive deep into the 1115. And so I'll just say to the group that we have this 1115 waiver that's generally speaking designed to help us help folks with serious mental illness. And you know, it's a contract that's been signed with the feds. So I think the likelihood that it would vanish is not strong. And, you know, CMS probably can unilaterally change the terms of that contract, meaning without our agreement. but not boundlessly. So I think it's just more of that concern about federal CMS being a terrible taskmaster to Illinois, to blue states in general, and to states trying to be generous with their Medicaid program, rather than that the 1115 waiver would somehow just go away. A couple of folks also raised questions and issues about, our ability to cover immigrants who are not eligible for federally funded programs. And I think really the big takeaway is that any really significant funding pressure caused by Medicaid cuts, and again, Medicaid cuts look like a whole bunch of different things, right? They're not going to, stand up there and say, we're slashing the Medicaid program, hoping that people go uninsured and die, right? They're going to say, we're improving the Medicaid program. It's going to be the Medicaid improvement to bring it into the 21st century bill, right? They love that kind of language. And it's going to have, work requirements and per capita caps and all sorts of things, which are all just cuts. Those cuts will be passed directly to all states, including Illinois, and they will put tremendous pressure on, our ability to be expansive, even in the ways we've been able to be in Illinois for folks who can't get federally funded benefits. So it's a ripple effect
Yeah.
that we're going to see as a budget matter.
Yeah, I think, Carrie, to add to what you're saying, the other thing they love to say, and they're gonna say a lot, is we're giving this back to the states. We're giving states flexibility. But when the flexibility looks like reductions in the amount of federal funds, as Carrie and Stephanie talked about, the only flexibility we'll have is figuring out how to make do with less. So that, yeah, it's going to be a messaging gauntlet and making sure that folks understand, as Carrie said, any change to Medicaid we know they're going to propose is a cut to Medicaid. Any change in federal funding is a bad thing for states. And they're doing it all to pay for tax cuts for the wealthy and corporations. I think that messaging can be really effective if we can get it out there.
Yeah, and I'll just add, there are a couple of questions about emergency Medicaid and about new arrivals. So in general, and again, we don't have enough time to go into it all, there have been some changes to the programs that have been paying for cash food and medical assistance for people who are applying for asylum, and that's chiefly the VTTC and AATV programs. We have a lot of information on our sister website, Help Hub, and I'll put Help Hub into the chat if you want to, if you're working directly with patients or clients. Carrie and I and Kathy and Tim, we answer questions there, and we can get directly involved if you have individuals who need help getting individual care, or their applications have been denied, or anything like that. Would be most appropriate to post there so we can help you with it individually. And the other question about working with national organizations, we're all working a lot with national coalitions, and many of them lead on these efforts, and we provide a lot of information from Illinois, as well as coordinate messaging with them. Carrie put in some, I think Nadine did and I did, but Families USA, Protecting Immigrant Families National, Community Catalyst, Center on Budget and Policy Priorities, the National Health Law Program, Georgetown Center on Children and Families. You'll see those organizations in all our links, and they have a lot more ability sometimes to do the DC lobbying, as well as to connect us with people who can specifically give us help on messaging and media. But as we found last time, it's really important to do this in Illinois. Only we understand Illinois. Only we understand the specifics of Illinois. We know our clients and our communities and our patients, and they need us on the ground here to provide those specifics. So it's really important, I think we found last time, not to just be like, okay, it'll be taken care of in DC, and we don't have to do anything. It's really, it comes to the states and to us to fight back and to protect what we have here.
Thanks, Stephanie. The last thing I'll add to that, the other thing that's so important to do at the state level is make sure today, tomorrow, and for the foreseeable future, people know that they have not lost access to benefits. We hear a lot of confusion from people, especially as the news picks up, about potential changes to these programs, cuts to Medicaid, people think their benefits are gone that day. So we have a challenge, but it's an important one, to educate folks, make sure they know how to access programs that are still available for as long as they remain available, while fighting to defend those programs.
And Kathy, I would just say really quickly that, you know, we, as you have said, we're not happy to be in this position, but we have been here before, and we definitely learned from being here the first time. But we need all hands on deck. Having, you know, folks who have been experienced in this fight is really helpful. But everybody, every stakeholder, we need every single stakeholder to be loud. They're also had experience round one, and they also got smarter and better at doing harm. And so this is not you know, we're not spectators. This is not a spectator sport. Saving access to healthcare in Illinois is going to require every single person who cares about it to do something in the near term to express how they feel and how they vote. So I just want to be clear, like, you know, we are all in, but we need every single one of you and every single person that you touch who cares about healthcare and health coverage access to be loud, and to make it clear that the idea of stripping health coverage and access to healthcare from people is unacceptable, continuously, really probably for the next 4 years.
Thanks, Carrie. I think that's a great note to leave on. So thank you all. Thank you to Carrie, Stephanie, and Timothy for helping me to present this webinar. Thank you to all of you who joined. We will expect 2 follow-up things. One, between today and tomorrow, you will receive an email from me with the recording and the slides. Feel free to share those broadly. And in January, once we have more to share about the sort of infrastructure and how to join and support Protect Our Care Illinois, you will see another email from me. Otherwise, if you want to get more information, any of our organizations are going to be sharing a lot. In the chat, you saw some information about EverThrive's Action Network and AIDS Foundation's Mobile Action Network, which is spectacular. So thank you all so much. And happy holidays, whatever holidays you may be celebrating in the coming weeks. I hope you get rest, and we will see you in January.
Thanks, everyone.